Okay, ma'am. Hi, everyone. I'm Dr. Malathi, a nutrition consultant at the onset. I would like to thank Dr. Sujata, ma'am, for giving me this opportunity, and Dr. Anne Agnes Matthew, who has been a constant mentor, and she's been a wonderful guide to me. And in today's session, we'll be discussing about what is ketogenic diet therapy and how does it work in children with epilepsies and other disorders wherein it is applicable. And share my screen. Dr. Anne?
Hello, Dr. Malathi.
Good morning, doctor.
Good
Can
morning.
you just share a few words before we start this session?
Sure. Hello, Dr. Sujata.
Hello and welcome, Anne.
Hi.
Thank you for moderating this session and guiding us through with this important topic.
Actually, what we've done is both of our slides are combined. So
great. Yeah. Who is going to share
Dr.
this?
Malathi. Dr. Malathi is going to introduce. So when you initially put it on, Dr. Malathi, the initial part I wanted to just mention.
Okay, ma'am. Okay.
Put on the initial few slides, no?
Yes, ma'am.
Are you able to share the screen?
Yes, ma'am. Are you able to? Not able to
see. No, we are not seeing it. Yeah.
I've already shared it. I just.
Do you want me to screen share, Dr. Malathi?
No, ma'am. I'll just do it again. I've already in this. It's been shared. I just.
I think through this Mayur's login, you have to just share the screen.
Are you able to see, ma'am?
Nope.
I'm doing it from my login actually.
Don't do
but
it
actually
from
I'm logged in from his ID only. So can you share the screen?
Then you have to make Anne the host.
Okay.
From Mayur's login.
Can I, how do I share it, Dr. Sujata?
No, that's what. No. Malathi has to use that Mayur's login and then click on Anne and then make her the host. Maybe you can stop the recording and then we'll do it.
Okay. And ma'am, you can try now. I have given the login to all the participants to share screen. Can you try once?
Yeah, I'm trying. Can you see my screen now?
Yeah.
Yes,
yeah.
Yes, ma'am.
So we basically put this combined mainly because the role of the two of us, the dietitian or the physician, clinician treating it, is inseparable. I thought I'll just introduce a little bit about the history, in the sense that there's so much of myths and so many things that happen around the diet. I'm sorry, my voice is very bad. I don't have a voice at all.
I'll read.
So history of the diet and something about the mechanism of action, its mechanism of action, some of its uses, some side effects and some practical issues. These are the ones that the doctors need to know much. And these practical issues are the ones that the dietitian always, that Dr. Malathi is the one who's always bearing the brunt of. which is why she's so closely connected to the family. So she'll speak more about it. So Dr. Malathi, will you read the first slide? I'll go to the second.
Doctor. As you all know, it is what is ketogenic diet? It is nothing but a high fat, low carbohydrate and adequate protein diet, because growth should not be compromised. So protein also has to be taken care, and it's mainly about reducing the number of seizures and then thereby improving the quality of life and reducing medication usage. So that's how it is aimed to be started with.
So while the entire concept of telling somebody that you have to eat loads of fat is terrible, there's a history to this. The history to this is epilepsy. Everybody thought epilepsy was called as a sacred disease. You thought it was possession, demonic possession, and things like that. And this is quoting from Hippocrates, who said that I'm about to discuss disease called sacred. He's saying that it is not in my opinion any more divine or more sacred than other diseases, but has a natural cause. It is supposed divine nature is due to men's inexperience and to their wonder at its peculiar character. This shows how good he was at observation. And then he goes on, Hippocrates then goes on to say, so from there, we've moved on from supernatural to natural etiopathogenesis, what is causing it. And 5 centuries later, there is, biblical 2000 AD, there's biblical references in the Bible saying fasting as a cure. This happened everywhere. People were locked up. If they had seizures, they thought, okay, demons have possessed them, lock them up, but they reduce seizures. So what we're trying to say is this is a fasting mimic. Ketosis happens in fasting, and this is the background. And from there, this is a cartoon that one of the neurologists use. We tend to use when we are teaching about ketogenic diet, saying, hey doc, what can I do? I have had hard to control seizures. One inclining to epilepsy should be made to fast without mercy and be put on short rations. So this is ancient Greek. That's 50 drachmas, saying that's his consultation fees, cash or charge. So this is some other stuff. Would you want to say, Dr. Malathi?
It's mainly about, I think, as you said, it helps in how does it help? The mechanism has been mentioned, wherein it helps in cognitive improvement, reducing the other, in some more slides, it is given about the mechanism, which we will explain. And it's earlier, as you said, it was mainly about fasting and then initiation. Now fasting is no more in use.
Sure.
Yes,
so the thing is that it's been around for 100 years, 1921. So, but then it took a long while for it to, so the whole thing for it to be popular, there was this movies in the 80s. Around the turn of the century, Meryl Streep. This movie was done by director Jim Abrahams, whose own son had very difficult to control epilepsy. So this First Do No Harm is a classic. And they noticed so much difference with their child who was having such bad epilepsy. Now the child was almost normalized with epilepsy, with ketogenic diet. And so the whole KD movement, there was Matthew and Friends, there's lots of other movements that started in the US and in UK itself, which popularized ketogenic diet. And that's how the entire movement started. So I remember when we were, where I was training in UK as well, we had more than 300 children with ketogenic diet. This is more than 15 years ago. Now the movement is much bigger. So currently between Dr. Malathi and I, we have more than 40 or 50 patients. So the mechanism of action is that it mimics, as we said, we are changing the substrate that you use, not glucose as substrate. You're using from carbohydrate, you're switching to fatty acids and ketones. So the main feature of KD is that the liver must be capable of producing ketones, meaning beta hydroxybutyrate, acetones, and acetoacetate. But this, you have to check that the tricyclic, the Krebs cycle pathway is intact. So for that, your mitochondria have to be intact. Your fatty acid metabolism, the beta oxidation pathway should be intact. So that's the only contraindication for KD. One must be capable of producing ketones. So KD, how it works, nobody really knows how it works. It works through various multiple mechanisms, targeting various biochemical pathways. and it is not very well understood. But we think that ketones have an anti-seizure effect. So which is why if you take away, so Dr. Malathi is here to talk today on how to ensure proper ketosis, which is a very, very complex thing. I'm there for a short while only to ensure that we as physicians don't destroy the ketones. Whenever the child becomes ill, they come to pediatrician, they come to intensive care, we don't take away the ketosis. Because if you take away the ketosis, you take away, just as you suddenly stop anti-epileptic medication of a child having difficult seizure, you take away that ketosis and you create them, give them a situation of wherein they have a situation for status epilepticus. So it plays around with the neurotransmitter milieu in the brain. So ion channels, ketones, they alter the metabolism and increases the negative inhibitory GABA receptor. So this is the GABAergic hypothesis. This is the primary hypothesis that we base, that KD works on, ketogenic diet works on. So the other hypothesis that we think is that blood-brain barrier and ACA, they inhibit presynaptic release of glutamate. So all of this, so some of the ketones as well, and that increases purine adenosine, it produces that, it upregulates it, and that also reduces the firing of neurons. So this is a very complex diagram, but all it says is that you need both here. So what's important in this complex diagram to remember is that you need increased ketones, so elevated free fatty acids. That happens when ketones are elevated, and you need reduced glucose. The moment the glucose goes up, all of this pathway is gone haywire. So there's a lot of upregulation, downregulation, all of that happening, but the end result is anti-epileptogenesis. And this is how, through various pathways, interconnected pathways, anticonvulsant effect of ketogenic diet works. So this is from an old paper, but we still believe in it. So as you can see, there's potassium channels affected, acetones, chronic ketones, interleukins are involved. Lots of things are involved here. So anti-epileptics, they work only through reducing neuronal hyperexcitability. And increased neuronal dysfunction is not good for mitochondria. And we also know that a lot of firing of neurons also causes inflammation as well. And there is oxidative stress, mitochondrial distress, and there is cell death. What ketogenic diet does is, so AEDs work only on epileptic hyperexcitability. What this pathway, this very simple algorithm shows is that ketogenic diet works in two ways. It works not just on epileptic hyperexcitability, but it also reduces oxidative stress. It works on mitochondrial dysfunction as well. So it is also indicated in certain mitochondrial dysfunction, mitochondrial disorders. So this is just to say how it works. And it also increases, especially in young children, very young children in whom neuronal plasticity is higher. It works by enhancing network plasticity and increased neurotrophic factors, neurogenesis, mitochondrial biogenesis, all of that it works on, mainly working on the hypothalamus, hippocampus, and striatum, works on all of these things. It reduces insulin, IGF, and leptin, and also increases, again, increasing ketones, adiponectin and ghrelin, and then how it works on various organs. Lipolysis, you do need lipolysis, increased insulin sensitivity, insulin resistance is reduced, increased parasympathetic tone, working in the liver, the heart, the gut, and on fat cells itself. So would you like to take it from here, Dr. Malathi?
Next slide, I'll.
Okay, so it was initially, KD was initially started, ketogenic diet was initially started as, because it was thought of as such a terrible diet, as in so difficult, that you used it for things that we thought were difficult to live with. Refractory epilepsy, those who had 50 seizures a day, 100 seizures a day, those who didn't really have a life. Like the child in that movie, First Do No Harm. But then it became the targeted therapy for certain genetic diseases like glucose transporter deficiency, where you get mental retardation. If you take this, children change. Dr. Malathi can talk about one of the children we have who has glucose transporter deficiency, Shravani Kumbar. Other who also has, who was on multiple anti-epileptics, whom we were able to stop all the anti-epileptics. She's only on ketogenic diet. Other neurological conditions like Alzheimer's, Parkinson's, this is all areas of research. So people really believe that cancer, so there are doctors who are now treating cancers with this. It's not cancercidal, or so, meaning it doesn't reduce the cancer, but it is static, because we believe that most of cancer cells divide so much that they take so much glucose that if you wean them off the source of glucose, that would be fine as well. So many people, as we know today, in fashionable upmarket shops, you would find ketogenic diet formulations, but that is not really ketogenic diet. Dr. Malathi will talk to you more about it. So for healthy living as well, cutting down carbs, basically. So there is strong evidence. So this is, you're looking at what is strong evidence, what is weak evidence, gray area. So there is strong evidence that it reduces. So cardiovascular risk parameters, how it works. It works by reducing the HMG-CoA reductase activity, reduction of blood insulin level, and so diabetes, increased mitochondriogenesis, reversal of hepatic insulin resistance, and weight reduction. So many people use it for that. So there's a reduction of appetite because you're eating so much of fat. There's a reduction of lipogenesis. There's increased lipolysis, increased metabolic cost, and glucogenesis and thermic effect of proteins. So how does it affect? We've already spoken about epilepsy. Cancer, how it works, not so sure. PCOS, again, neurological disorders. Suggested mechanism is ATP, increased ATP levels, ROS system, and reduced glucose metabolism. So these are the gray areas where there is emerging research. These are the areas where there is strong research evidence. So these are the list of things. So when we put autism here, there are people who believe autism is not a disease. Epilepsy is not a disease. Epilepsy is an umbrella term for multiple different things. Many genetic epilepsies, which are very difficult to control, ketogenic diet helps. Our child with the glucose transporter deficiency is a classic example of somebody who had autism, Shravani, that we were talking about, who had both autism as well as difficult epilepsy. Both the autism and the epilepsy improved on ketogenic diet. That is a well-known fact. So what it does is substrate delivery. It switches the brain over from glucose substrate to ketones. So pyruvate dehydrogenase deficiency, PFK deficiency, fructose kinase. In GSD, glycogen storage disorder, GSD type, myocardial type 5, and in certain cancers such as adenocarcinoma, that is gastric CA, prostate carcinomas, astrocytomas, and in cardiac ischemia. So these are the well-known, well-established indications for ketogenic diet. Will you go on, Dr. Malathi?
Can you share? Can you change the slides when shall I screen it again?
You can't change the slides. So can you see the slide? Side effects. Yeah. I'll change whenever you ask me to change.
So side effects, again, we have discussed how to address it also in other slide, but usually the side effects, what we are commonly seeing with the experience with our patients are hypoglycemia. It's very rare. Nausea and vomiting is very common. And the lack of energy and hunger in older children, yes, we have been seeing it in older children, wherein sometimes we are switching over to modified Atkins after a long time usage of classic ketogenic diet. Next slide, please. Next slide, please. So long-term side effects are like constipation, which is very common, and then dyslipidemia in up to 60% children, wherein we do change the ratio of fatty acids and help them by reducing or avoiding the saturated fatty acids, and then increasing the ratio of OFA and MOFA and things like that, and elevated liver enzymes, that's also more common. Weight loss, acidosis, renal calculi and gallstones, it's not very common in our experience. Protein loss, enteropathy is not very common. Yes, next slide, please.
I would like to add one thing here, Dr. Malathi. Renal calculi is very common if we don't monitor it. So we had one family with very difficult epilepsy who were, because of COVID, they disappeared to follow up. We monitor for renal calculi with urine calcium creatinine ratios every month or 2 months. We keep monitoring it. This family disappeared to Andhra. After a year, they came back and we did USG and the child had calculi. It's not common because we monitor it.
Yeah, that's true, ma'am. Ma'am, next slide, ma'am. Yeah, when this is also like as Dr. Ant rightly said, because we monitor very closely hypoglycemia, we in the beginning itself we would explain then how to overcome it, and we have to check it with the regular checking of blood sugars and all. They have to give sugar-free orange juice or lemon juice, which is homemade only, or a sweet lime juice, and then depending on the age and all, we would give them a range of about 15 grams to 30 grams. One, it's not like continuously in a day, only when there is a hypoglycemic episode. And treat, we'll tell them to treat it as hypoglycemia only when it is below 60. The sugars are below 60, because very often they get confused with even 70, 80 to be hypoglycemia.
Our aim is 70, 80. Our aim is 60 to 80. We don't want it to be anything outside that range. And we usually tell them that when you're taking the, and this is something for for the pediatric team to note, that if they are hypoglycemic and you end up giving them IV fluids, try and not give them more than an hour of IV fluids. You don't give them boluses, because their system is adapted to, it's not the same hypoglycemia as you treat for other hypoglycemia. If you give them a bolus, they don't do very well. And even if you give them IV, say dextrose 5% containing solution for an hour and you monitor it again, they're usually fine. They do very well even perioperatively if you give them for long periods of time just non-dextrose containing IV fluids.
So contraindications, I think Dr. Ann will be able to explain about contraindications.
This is the only absolute contraindication is where your liver is not able to produce ketones. So this would be specific defects in the beta oxidation pathway, like carnitine palmitoyl transferase type 1 and type 2 deficiency. So beta fat oxidation defects such as MCAD and porphyria, where the liver is already very weak. So these are the three things that are absolute contraindication. So because of this, we always assess tandem mass spectroscopy and check for the fact that the beta fat pathway is intact, CPT is intact, that they're able to produce ketones. We do this before we start ketogenic diet. So even if you are in the ICU, one of the places that you have to start emergently somebody on ketogenic diet, say, for example, if somebody's got super refractory status epilepticus, and you want to start them on ketogenic diet, then you would need to send a dried blood spot to check for acyl carnitine pathway to make sure that they are able to produce ketones. So you use with caution in liver disease. We still use, you can use it, but use with caution again, because the liver is the primary source of production of ketones. Metabolic diseases that involve glucose and ketone homeostasis, but this is with caution. But contraindication, absolute contraindication is MCAD and other things in the beta fat pathway.
So efficacy, as the data is presented over here, as per the review articles and other research articles, it has been proven to be highly effective ketogenic diet in in management of epilepsies. And again, having said that, there is no particular guideline to fine tune and how to change and all that. So, but then with experience and based on the basic guidelines, which has as per the review articles and all, we have been fine tuning it and working very closely, monitoring the week on week basis in the beginning, and later on with a gap of 1 or 2 months, because only then we can address the side effects and long-term effects. And the fine tuning is extremely important, and also team approach by neurologist and dietitian can help them improve seizure control and thereby reducing the medications as well. Next slide. The dietetic goals, obviously, it will be to achieve ketosis by providing fat for metabolism, ensuring that growth is not compromised, ensuring nutritional well-being, as well as sustainability. It's very important. So initially, maybe they'll do well. Maybe the child is cooperating, but for a long-term, on a long-term basis, if the same recipes are continued or the same ratio is continued, then it is very difficult to follow. And there will be a drop in ketosis and thereby again coming to square one. So palatability is what we normally focus, and also it is possible to the compliance issues also to be managed on a one-to-one basis. Next slide, please. KD initiation in our current practice, we do not recommend hospital admission. In Indian scenario, it's all everything like cost is one factor, and then other issues are also there for the concerns will be there at the initiation itself. If there are a lot of concerns, then we will not be able to help the child with KD. So we do not recommend hospital admissions. We do it at OPD level itself. And fasting, we don't recommend, because even without that, we are able to achieve ketosis at OPD level. And also we do recommend an initial, unlike earlier, wherein first day is 1:1, second day 2:1, third day 3:1, and the fourth day 4:1, continue the 4:1 ratio. That is what has been followed earlier. But in current practice, we recommend them at a lower ratio, and then see how it goes, if it is helping them. For example, in case of Shravani Kumbar, the case wherein ma'am was mentioning, we did start with a ratio at 2:1. The child was doing very well even for up to 1 to 2 years. The child was comfortable with that ratio, and there was no compliance issues, and we were continuing it. And only recently we have increased it by another 0.5, that is 2.5:1 ratio. Like that, we would closely monitor and increase, not like giving immediately within 4 days of 4:1 ratio. And again, the guidelines are there, which I will explain about how do we increase the ratio. And there is no carb washout diet, unlike other clinics where they are practicing carb washout diet. It can help in the patient to some extent. By avoiding the carbs, they will be understanding it, and it may help in sustainability. But when it is also helping without carb washout diet also, we are able to achieve ketosis. And it is also saving time. Next slide, please. KD initial evaluation, pre-KD workup, doctor would recommend all these investigations, and they would get it reviewed by the doctor, and then they would meet the dietitian to start the ketogenic diet. So there are some of the tests which are compulsory and some are optional.
So one of the reasons why we do this is because we have a baseline and we compare it to that baseline, and we keep comparing it, and they do get dyselectrolytic, but they get hyponatremic. They do have dyslipidemias. They do have, as we mentioned, urinary nephrocalcinosis, tendency for nephrocalcinosis.
The variables are in energy, because everything is based on the energy intake recommendations, what is required for that particular age group. And it would, the duration of the ketosis, it would range from weeks to some months. So initially, within few weeks, we are able to achieve ketosis. Again, if it takes time, we would tell the parent to wait for some more time. And if it is negligible, it is not, we have never seen a case wherein it is negligible for months together. The ketones are, at least the moderate ketones, are achieved within few weeks itself. And they need to wait for up to 2 months and then continue it for 2 years. And some are comfortable, they are able to continue even after 2 years. And the calories, again, we decide as per the recommended dietary intake by ICMR guidelines. And again, the keto ratio, we would calculate based on the calories only, the calories. And again, I will explain you in the other slide how do we do the calculations as well. The keto ratio, it would start from 1 to 4. Yes. Meal plans, number of meals. Meal plan, it would comprise the meal pattern and the number of meals, including snacks, the total number of either meal or snack, or a feed if it is in a child on a NG tube or PEG tube. So overall, it will be the number of feeds. Why do we calculate it? Because we need to distribute the keto ratio uniform throughout the day, so that there is a proper ketosis achieved, and then sustainability will be there, uniformity will be there, and lot of other side effects also can be taken care. And the timings, we don't insist the parent to follow a strict timing, because it is not possible to follow fixed time schedule. It is according to the child's sleep pattern, according to the time that they take medication, according to the time they wake up, their physiotherapy time, the rehab time, all those are all considered. So we do leave it to the patient, to the parents only. According to the child's timing only, they can take. All they need to do is leave a gap of 4 to 6 hours and check the ketones. And all they need to do is just to follow according to the plan, the number of meals that are mentioned. So if it is mentioned as 7 per day or 6 per day or 4 per day, they have to finish it in that day. That is a compulsory, because otherwise they will not get the required fat intake. And the quantity, again, it would be according to the meal plan. And we don't suggest in terms of teaspoons or tablespoons, because there will not be accuracy and there will be overfeeding or underfeeding in that case again. So we do recommend them to use a digital kitchen scale and follow it, measure it properly, accurately in terms of grams. The eating pattern, it is completely based on the ethnic and religious influence, spiritual and other things, what they follow, their ethnic influences, and also according to their pattern, whether it is a vegetarian diet or a non-vegetarian diet. Like that, we do take a recall, that 3-day dietary recall, initial nutrition assessment, and then decide, calculate the meal plan. And the liquid allotment, we do not restrict liquids. We do allow liberal liquids, but then if they are on a tube feeding or anything, then we will recommend according to the guidelines and per kg body weight, how much ml is required, like that. Next slide, please. Energy, usually we don't recommend exactly according to their age group. It is only 75 to 80% of the RDA. And again, other factors are also considered, like their activity level and their BMI, if it is in a child above 1 year. And again, if they are putting on weight, we do add on calories. If they are reducing weight, we do reduce calories when they are putting on weight. We do increase calories when they are losing weight. So again, we would not increase more than 100 kilocalories at a time, because that is, as per recommendation, it should be only 75 to 80% of RDA. Next slide, ma'am. So in this example, 1000 kilocalorie diet recommendation is been mentioned. So with using this as an example, the calorie recommendation, I've just given the distribution of fat, protein, and carb under a 4:1 ratio, 3:1, 2:1, and 1:1, just to give you an idea. So obviously in a 4:1 diet, the fat content will be more, minimum 100 grams, because according to the calorie that is mentioned over here. And the protein will be like this in this case. So it's always adequate. It's not going to be very high protein, but adequate protein. And again, based on the weight loss or anything, we would add on the protein. And then based on the current weight of the child, if the child started on a keto diet at a very low weight, then we would increase the protein. Otherwise, the distribution will be like this. So what you have observed in this slide, it is always like, it is in a descending manner. When we start with 1:1, the carb will be more. When we increase it up to 4, carb will be very less, up to only 8 to 10 grams in a day. So that is under the classic KD. And then medium chain triglyceride diet. There is other diets are also followed which are in clinical use, low GID diet and modified Atkins diet. But initially, we would recommend that the child is on a CKD, because achieving ketosis will be easy, though it is more restrictive compared to other diets. But after a period of time, after achieving ketosis, and maybe after 1 or 2 years, then if the child is not cooperating well, lot of complaints issues are there, or if the child is growing and they want more flexibility, in that case, we do sit with them, and then we will change it to be modified Atkins or MCT diet or things like that. And again, the distribution is mentioned over here in that distribution of fat, protein, and carb. So when you compare that, there is a more amount of carbohydrate is recommended in other diets compared to a classic keto diet. Next slide. So fine tuning. How do we do the fine tuning of the keto ratio? Keto ratio is again 1:1. What is 1:1 ratio? In this, the fat and then relative to carb plus protein ratio will be the same. Then in child in below 6 months, 0 to 6 months age, which is a very young age, we would not recommend more than 1.5 as per guidelines. So it will be only start with 1:1, because there will be more issues with the tolerance, and then we might increase it to 1.3 or maximum 1.5 if there is no proper ketosis. And then above 6 months to 1 year, we will start with 1.5 ratio initially, and then increase it up to 1.8, or max it will be 2:1 as per the requirement. And that means if there is no ketosis, or if there is ketosis but it is not constant, then we would increase it up to 2:1. Otherwise, we will maintain it at 1.5 only. Then if it is above 1 year child up to 3 years, Maybe we'll start with 2:1, increase it by 2.5, and then increase further up to 3.5 and continue at 3:1 itself. Unless and until it is a child above 5 years, we will start with 2.5 or 3:1 initially, and then increase it up to 3.5:1 ratio and further to 4:1 and continue it. And above 5 years, definitely we need to start with 3:1 and then continue, start to increase it up to 4 and continue it. Next slide, ma'am. So what are the fat sources? We normally suggest the ones that are already started by the parents. In some families, ghee would have been, most of the families, they start ghee earlier. So we will tell them to start with it for some time at least, unless and until their lipid profile is bad. So then ghee, because we do not recommend something which is not started in the family. So we start with normally ghee and then the regular oils that are used. And if they are already using cheese and cream, we might switch over to that as well. So these are all the fat sources, because 1 gram of fat gives 9 kilocalories. It will help us maintain the calories as well. Next slide, ma'am. What are the problems at the initiation? Calorie intake. So as per the 3-day dietary recall, we would have calculated the calorie recommendations as, for example, 1,500 kilocalorie per day with a 7 meal pattern and the fat ratio, keto ratio being 2:1. In that situation, the child is not now it is not a normal diet, it is a keto diet. In a keto diet scenario, the fat content will be more at each meal. So the child may be feeling full and unable to finish 7 meals per day, 7 meal or snacks per day. In that case, the calorie intake has to be fine-tuned by again changing it to 4 or 5 per day and then reworking on the calories, because otherwise there will be a low calorie intake and also there will not be proper ketosis. Then meal and snack number, as I said, initially as per the recall, we would have calculated it as 7, but there are situations wherein child is feeling more hungry and the child would want a 10 meal ratio or a 12 meal ratio, second hourly pattern or something, then we have to again change it back. So these things we would tell that these are concerns from the parents that whether they can change it on their own. But we will suggest not to change it on their own, because they will not be able to calculate the keto ratio of each meal. And the ratio we will again fine tune in that scenario. And the carbohydrate proportion also will be fine tuned along with the fat ratio. And sometimes they get confused or they will be misusing the free foods. When we tell them to give a thin buttermilk made with only half teaspoon of curd, just to give it in between for the sake of fullness, if they are not able to follow properly, or that the child is demanding something, or a lime water, then cucumber salads and all that, which do not have much carbohydrate and negligible carbohydrate sources, when we recommend them to that it can be allowed, but they misuse by giving it very frequently, thereby adding on the carbohydrate content of it. And then they do give by mistake, or sometimes there's some just like that they might somebody, the grandparents or somebody, they might give them chocolates or some sweets or something, in spite of being not allowed, explaining at the time of the initiation itself. In spite of being aware, they might give, and then they're worried about the ketosis. So we do tell them not to give any sugar-based things, and everything should be sugar-free. So they can also use sugar-free sweeteners like stevia or sugar-free natura to give the sweetness, or the fruit itself. There are definitely in the plan, there will be 2 or 3 fruit-based recipes. So that itself can give them the sweetness, the natural sweet. The fructose will be there in that anyway. And the recipe preparation, again, it is not like restricted according to what we give. It is not like restrictive diets wherein we generally tell them to follow. They can't follow a proper their own recipe by using the keto ratio. So they have to follow the recipe that is mentioned in the meal plan. Having said that, if they want to give it in a different way, definitely they will discuss with me and with a dietitian, and we will definitely tell them to eat according to their way, but the ingredients have to be changed a bit, and then it has to be fine-tuned. So even the recipe can be discussed and fine-tuned. And for demanding eaters, again, we do change the recipes very frequently. The fluid, anyway, we don't tell them to restrict. The proper usage of weighing scale, They have to use the tear option. They have to use the empty weight, the weight of the empty container, all that they have to follow. So sometimes we do a video call and then monitor how they are weighing. Initially, it requires a lot of time and effort. Wherein we tell them like whether they are monitor their weighing measurement also, whether it is correct or not. Because with the simple basic mistakes itself, everything can go wrong. So the weighing itself is wrong, then the calculation, everything would go wrong. And we will tell them not to follow the teaspoon or tablespoon method. Next slide, please. So in this case, with a 1000 kilocalorie or 980 kilocalories, it will require. This we would start, and for the sake of explaining the calculations, I have taken this example when 1:1 ratio, how do we calculate? So it's a 1 part of fat, which means 9 kilocalories from 1 gram of fat. So 9 kilocalories we have to add to the combined thing of both the carb and protein calories. That is 1 gram of protein gives 4 kilocalories. So total it becomes 13 kilocalories. And in this scenario, it is like 100 kilocal per kg body weight up to 1 year. Usually it is like that. Then if we take it as 980 kilocalories, we have to divide it by the DU. So DU is nothing but it is the both fat plus carb plus protein combination. So wherein the DU value is 13 kilocalories. Per 1 DU, it is 13 kilocalories dietary unit. So when it is 1 DU 13, then for 980 kilocalories, what is the DU? So then you will get the 75.3 or whatever when you divide it. Then that will be the DU. So the dietary unit, now you have calculated the dietary unit. How to calculate the fat recommended per day, fat recommendation. So for that, you have to multiply it with 1 because it is going to be a 1:1 keto ratio. Then it will become 75.3 grams of fat. Then protein, again, you can do it as 1 to 1.2 gram per kg body weight. So when you take it like that, it is 11.7 grams. Then you got already the fat recommendation. You have got the protein recommendation. Now what is left is the most important thing, that is carbohydrate recommendation. That has to be subtracted from the DU and protein from the DU. So the protein has to be minus from the total DU, which is 75.3, that is 63.6 grams carbohydrate. Now we have finished the calculation. So what is the next step? The next step is to calculate the carb, protein and fat ratio per meal, because it's only the per day that is calculated. So how to calculate the per meal carb, protein and fat ratio? For that, we should have everything ready, the number of the diet which has been calculated from the dietary record, the mean nutrient intake of the diet which is calculated as per the 3-day diet record. So the mean nutrient intake will give you a clear picture. It's not like one single day will not give you reliable data. We should be able to collect the 3-day dietary record and then take a mean nutrient intake of that, and then see number of meals that the child is actually taking at home. So we cannot change it. We should follow the same number. The child is used to take only 4 recipes or 5 recipes. Then if it is a 4 recipe, then we have to divide 75.3 by 5, 63.6 by 5. That will give the amount of protein per meal or snack. Next slide. So we talked about 1:1 ratio. In 2:1 ratio, same pattern has to be followed. All we need to do is double the fat because it is 2:1. So we need to multiply it with 2 instead of 1 with 9. So 9 multiplied with 2, you'll get 18. That will give 22 kilocalories per dietary unit. Then again, that much has to be divided with by total number of calories per day recommended. Then again per day carb, protein and fat, thereby calculating the per meal carb, protein and fat. This gives the actual keto ratio per meal or snack. Next slide. So in 2:1, definitely the fat content will be more. Protein remains to be the same, and carbohydrate will be less than the 1:1 ratio. In 3:1 ratio, we have to multiply the fat portion as 3 with this thing with 9, because it will become 9, it will become 27 and 31. So in any scenario with 3:1 ratio, 31 kilocalories has to be there, but the calorie content will not be the same in all cases. So as per the calorie recommendation, the fat content is calculated, and similarly protein and carbohydrate per day, and after that per meal or snack it has to be calculated. In 4:1, definitely there will be 40 kilocalories, and then the calorie intake also will become more in this case. The calorie intake remains to be the same, but if 4:1 is calculated for a longer time, the fat content will be more, and it is suitable for children above 5 years, the 4:1 ratio. But sometimes, as per the doctor, referral doctor, we would do it in a case wherein there is no ketosis or something, even within 2 years. Next slide. So keto recipes, we do recommend many recipes. Few things I have listed over here, like cakes and then different cookies and all, and the different varieties of cakes, different varieties of soups, and soy milk mixed. Most of the things for vegetarian keto diets, we do recommend soya products. And if they are not relishing soya flour or not used to it, then we will also have other things in the plant like coconut powder, then keto flours, then almond based recipes. So that's for children below 2 years, semi-solid diets are recommended because they are not used to it, and there are other issues also. Swallowing issues, if they are having other issues, then rava porridge, then they are able to have chapati. Sometimes they like to have it just for the sake of taste, though it is blended or hand mashed. Then idli and dosa is normally demanded by our patients because it's all South Indian based diet. But again, the type of idli, the ingredients would change. And then dosa, definitely they're happy where to make it with coconut flour and little bit of soya or keto flour. And they might also use chopped vegetable to it, and like a uttapam, they are able to prepare it. Pancake, they will do it either with egg or without egg, and they will also add some enhancers like fruit puree and things like that. And then egg based, chicken based, fish based, soya based and rolls, they are usually relished because some children like that to be the crispy things like this, so they can just deep fry it, or they can shallow fry it, and they are able to enjoy these recipes. Samai khichdi it's like a millet based things, especially till the parents of families in Karnataka, they would prefer to have, when they tell them to avoid rice completely or very negligible 1 or 2 grams, it is not practical. So they will be happy when we are able to add at least 5 grams of millet flour or samai flour, sama and all, which is locally grown, and it has been a staple diet. And soya almond shake, it is also relished by the children. Next slide, ma'am. Apart from the natural sources, sometimes we do recommend some formula like coconut oil. This coconut oil, anyway, MCT oil can be used, or regular coconut oil can be used. These two we don't recommend much. But what we normally recommend is a Keto Kid formula. It's only the cases wherein they are not able to prepare the foods from the natural sources, and also during their travel and their visits to the doctor and physiotherapists and all, just as one backup feed, they will be able to do it if we are able to give them with the Keto Kid or Keto Cal formula, wherein they need to just mix this. Yes.
Just one interruption. Keto Kids is extremely expensive, no, Dr. Malathi?
Yes. Yes.
One tiny dabba is how much? 400 grams?
Around 2,000.
It's only 400 grams, no?
Yes. That's the reason why we don't encourage much, but there should be a backup to them when the child is sick or unable to have natural sources, or unable to prepare. In such situations only they can use. So they don't have to use it on a daily basis.
Bringing out this discussion for the sake of our intensive care colleagues, because using it in intensive care becomes a bit difficult. If you're, if your child is about 10 kgs, you would need more than 1 dabba a day, no? 1 tin a day.
1 or 2 days, based on the fluid. And
based on that. So you may even need 2 dabbas a day if the child is about 20 kgs. Am I right?
Yes. But then in ICU, if it is a critical case, and then if there is an issue with the osmolarity and the GI intolerance,
then it is the best thing
in
to do.
such case, it is best. And other products are also mentioned like Newsomine, Neutral Light, and egg powders. These are extremely useful. They just have to mix it with the rice or chapati. Chicken powders and egg powders and all, if they are not able to have a regular recipe. Yes, next slide.
There's also an Indian product called by Pristine, no?
Yes, Pristine also is called.
Yeah, but they're not able to achieve 4:1. They can only achieve 3:1, only up to 3:1. So the British biologicals, that's an imported one. The Keto Kids, that's what Dr. Malathi was talking about. They're almost double the price. Yes, but they have better quality. They taste better and compliance seems to be better, but it's more expensive.
More expensive, and it's not a single product. Many times even the doctors and dietitians and other fraternity, they just give it directly. Actually, directly we cannot give any single product without calculating.
Yeah.
Though it is mentioned as 4:1, it's only the product ratio is that much. But when it is interpreted in terms of a recipe based on all these calculations, it cannot be just given like that as per the label on the box.
Which is why people fail in ketogenic diet if they don't know how to calculate ketogenic diet. You can't simply buy the dabba and turn it to it, say you add this much volume of water to this much formula and get 3:1 or 4:1.
That's not possible. Okay, ma'am, next slide. Okay, this is about ketone body check. It can be done through urine, or blood can be used as a sample. So for blood, we can do it with a blood ketometer, wherein the strips are different, but we can use both. They can use both the glucose as well as they can measure the ketones. With the urine keto diastics, usually we use that base product. That is actually the strips are given in the most of you would have seen it in your ICU setup and your wards and all that. I don't have to explain, I think, about the keto diastics, but checking, yes.
But we do, so we do, this is part of the team effort of when families are going through the ketogenic diet. We ensure that they are trained on how to check it. The other practical point is that the keto diastics, urine keto diastics is much cheaper. So we usually tell them, okay, this is the option. But the blood ketone, as you can imagine, is real-time ketones, whereas urine is older. So it's a recall of what happened before in the body. So, but blood is for 10 strips is almost as expensive as like hundreds of whatever of the urine. So we usually tell them have a backup blood ketone meter 100 strips, but use urine more regularly. But once in a way initially, or when they are sick in ICU, we tell them you do the blood once in a way, more frequently. We've gone through this. Shall I skip through this?
I think yes, we have already explained this. Then this is a ketogenic diet monitoring form, which is very important for us to fine tune. Without this, we will not be able to fine tune their diets. So they need to enter these parameters like glucose, daily glucose checking. Initially, it is 2 to 3 times a day, but later on the frequency is reduced. We tell them to do it only twice a week like that. And the ketones, again, if it is well established, initially it is actually 3 times a day. Later on, it becomes only once a day or 3 to 4 times a week. But that again depends on their review by the doctor's review, and later on by the dietitian also. They'll check and they will tell. The number of seizures and all, they have to document in this. Though they don't have to mention OFC over here because it has to be done at a clinic only. IBW, we will normally calculate. They need to check weight, not daily, but every week, and then enter it over here. So this is, and the remarks column is also there, wherein there are times wherein 4 meal pattern is not followed. So number of meals, I think I missed out one column over here, that is number of meals. That is extremely important. So number of meals also they are not going to mention. And if they are going to mention 7 as per the plan, the remarks column, they can write it as 5 if the child is not able to eat 7 on that particular day. But if that continues for a longer time, then I will have to fine tune it again by changing over to 5 and then again reworking on the calculations. The side effects and their treatment. So if it is a short term, like dehydration and then hypoglycemia, nausea, vomiting, anyway, medications are given before food, like vomit, like Domstrol and all that, and Junior Lansol for acidity reflex issues and all. Sometimes they don't give it regular basis, or even after giving that, if they are facing issues, then we might cut down the milk intake in their diet, or we might do some changes by increasing fruit-based or vegetable-based recipe, and or maybe we will tell them to drink more water and add on some free foods in between, like that. And the constipation, again, definitely the vegetable-based recipe is compulsory. We do emphasize that part, because they just give only the list might have a fruit-based, a cereal-based, a vegetable-based, things like that, but they just use only one single thing, and then they would complain about constipation. So there should be more balanced diets in there. Even within the keto recommendation, the diet has to be more balanced. So we do tell them to increase the vegetable recipe more or fruit recipe more in case of constipation, and other medications also if required pertaining to constipation issue. Hyperuricemia, we have not come across till now, as doctor said, because we monitor closely, maybe we have not seen them, but we do tell them to take more water and cut down the protein. If at all we have it, then we need to cut down the protein intake, and then, or some other changes we need to do related to this based on
hyperuricemia, I've seen more in the UK, mostly because they tend to have more meat and stuff. We have more plant-based protein and fat, so I haven't seen that much in India.
In India, in adults, it is more in India.
Okay, in our children, I have not seen, but I've seen it in UK.
Long term is again loss of bone density, growth retardation, renal stones, hyperlipidemia, then definitely there will be the medication list. Definitely calcium and vitamin D supplements are given, so maybe it can be tackled as a preventive measure itself. And then growth retardation, it should not be allowed at all when there is a close monitoring and then fine tuning. And then renal stones, again, as ma'am said, one case again, they have to actually approach us and to address these issues. Hyperlipidemia, definitely we are actually treating these cases also, but then there are sometimes hypertriglyceridemia, which is taking a longer time to reduce it, like the Shami.
This renal stones business, we preemptively alkalinize their urine, give them potassium citrate or hydrochlorothiazide or something like that, to make sure that they don't have. So you don't see anybody with nephrocalcinosis, renal stones, because we put them on it. We monitor and put them on it. This particular family disappeared because the child had well-controlled seizures. The child was having bad epilepsy, but was well controlled. It was COVID. They went off to their village in some small place in Andhra, and they came back after a year. And when we did the kidneys to ultrasound, and we saw nephrocalcinosis.
Practical issues, keeping everything sugar-free is the biggest challenge, including medications. So they are not aware, even when they go to the referral doctor or when they go to the local pediatrician.
Recent experience, last week, Mysore, pediatrician, dehydration. What happened?
Jasvita.
Yeah, ORS was given, Electral was given.
Yes.
You can't give Electral.
That DNS also, they, ma'am, I think you can highlight that point, DNS and plain NS.
Yeah, so we continue to give 0.9% NS or something like that. Anything that is non-dextrose containing, they are absolutely okay. Even if, say, the child lands up in crisis, say the child has got an abdominal crisis and you're going to put them 48 hours nil by mouth, most of the time these children do well. You just have to monitor closely their GRBS. And if the GRBS is okay, then you don't need to, if the GRBS at any point drops, only for that hour, you have to give them dextrose containing fluids and then change it back.
For under general anesthesia, yeah.
Okay, so this is the one area where all of us need to work together. We all come together only for this particular thing. Anybody with a ketogenic diet, they come in contact with pediatricians. We usually write letters to the primary care pediatrician, whoever's taking care of the child. We talk to them and tell them, this is your child, this child. So this child in Mysore, there was no ketogenic dietitian in Mysore. This child did well with epilepsy, but the child was given electron. So how we overcame this was by talking to the pediatrician and sort of educating them a little bit without condescending or anything like that. But so for your purposes, you should be able to liaise with the ketogenic diet. And we check more ketones and more glucose at that time. You also make sure they don't have dyslipidemia, because these, dyselectrolytemia, because these children are more prone to dyselectrolytemia. They are prone to acidosis. We check bicarb as well. Check for the, as we said, hypoglycemia. So keep them nil by mouth as usual, but to avoid IV fluids. We've already said all of that. For GA is more than 3 hours, you have to monitor for acidosis, bicarb, ketones, glucose, and manage hypoglycemia or hyperketosis. Only if there is hyperketosis, then you monitor for 10% dextrose. Then you change it to lower carbohydrate containing fluids. So only if bicarb is less than 7.2 would you give bicarb IV correction.
Follow-ups are extremely important because there might be high ketosis or there might be not adequate ketosis. So when there is high ketosis up to 160, 80 is a regular one, which is expected, which is supposed to be good for urine ketones. Then if it is more than that, like up to 120, 160 like that, then we do recommend them to increase the water intake, because otherwise already they, by the time they report to us itself, the child would have been facing dehydration issues and all that. So again, follow-ups are required because, as I said, meal ratio will not be, calorie intake we will not be able to assess. Meal ratio we will not be able to assess. Ketosis, whether present, not present. If not present, what has to be done further? All these things we will not be able to interpret the data. So unless and until they maintain a keto monitoring form and then come for regular follow-ups. Other factors are also considered, like appetite, recipe, meal time, number of meal, digestion issues, liquid intake, frequency of urine. Sometimes checking urine ketones itself becomes a challenge because child was not able to pass urine properly enough, and then they're on diapers and all that. Then if it is continuing for a longer time, we do tell them to check the blood ketones. The number of seizures, frequency and intensity, change in medication, checking the weight scale. If sometimes if it is not working, then they need to check that as well, and urine routine advised and check during follow-ups if there is any infection or something. Most and other issues, if they are very severe, loose stools more than 10 times, watery stools and all, we do tell them to visit their local pediatrician, but they have to explain them about the ketogenic diet, the child is on ketogenic diet, and then connect them to our doctor also if required. Would you like to add on anything, a follow-up slide?
I think we've covered it in most of the places.
Yes.
Yeah, sure.
Next slide. No? I think it's done. So while managing ketogenic diet, there is a chance of getting a nutritional deficiency, especially the micronutrient deficiencies. So we need to actually check the micronutrient intake by simply checking whether they are taking adequately the rich sources of vitamins and minerals, and then add on something like pumpkin seed powder and sunflower seed powder, the seed mix, flax seed powder. These things also maybe in a simpler way or with a minimum quantity. We can recommend in as an add-on to their drinks or the recipes that we normally recommend, because nutrient deficiencies are again under concern matter. Next one. Ma'am, next slide. Okay, next point. So Carnivore is actually given at the beginning itself. For dyslipidemia, only adjustments are done with the fat and calories and fat especially. And also we can increase the protein a bit, and lack of fiber is like constipation is a common issue. But again, it also comes under nutritional deficiency if the diet is not balanced.
So regularly, we don't routinely supplement carnitine unless somebody is on valproate or something that is damaging to the liver. If there's liver dysfunction, we tend to give carnitine. So these are all the micronutrients.
D is given as a regular routine, I think, in the beginning, yeah. But C and selenium, we don't have.
A to Z.
A to Z, yes.
Yeah. Selenium is also there in it. We give all this.
And the dietary sources are also given here. It can't be used liberally, but it can be a part of the plan.
Yeah.
As a minimum dosage. These are again taken care of. Calcium, yes. Thank you.
Very extensive talk. Thank you so much. I think that was quite useful for all of us. Any questions from the team? I think we want to reiterate about how to monitor. I think the concerns have always been the hypoglycemia, the do's and don'ts. It would be nice to just kind of put a summary slide there for future, just to put like the do's and don'ts, especially for us clinicians, although you have involved everything in the slides, just as a reminder for us.
I will go back to this only. This slide is the most important.
Exactly. Yeah.
This
so
slide
and that slide. Yeah.
And this slide.
Yeah. Yeah. And also the sugars, what is the threshold?
So we tell them
give.
in the
beginning
itself, we tell them, no Tirupati Laddu.
Yeah. Yeah. Any questions, T? So Sindhu, you
I have
with KD. Yeah.
That's what, because most of the time in the ICU, we will come across when they are in the active phase of the refractory seizures, intubated, and they're already on thiopentone infusion. So if we have to start a keto diet in those childs, because most of them are intubated, and then, with the Ryle's tube only we will be starting. So how do we go about in those children, ma'am? Like, if you start with that keto kid, because that's what we did with the last baby. We took the keto kit, and I think our dilutions were not proper. So I just wanted to know how to go about at those times.
So may I know whom I'm talking? Who's
Sindhu, ma'am. Sindhu.
Dr. Sindhu. That's a very good question, and the answer is that invariably, because I cover so many ICUs, invariably every single ICU gets it wrong. And the reason you get it wrong is because, number one, you're a good ICU, so you know that nutrition is very important. You start somebody on NG feeds. Your first is normal feeds, because you don't want somebody who's on super refractory status to not have nutrition. You don't want them to be on catabolism. You want them to be in anabolic state. So you give them that. There is where you get the help of the dietitian very closely with the pediatric team, with the intensive care team. But while you're doing it, go through with a fine-tooth comb what you do, input, output. You go through your electrolytes. Go through what are you diluting your midazolam with? What are you diluting your ketamine with? What are you diluting your thiopentone with? Antibiotics. Is there any dextrose-containing fluid? And keep going through from A to Z. Every single thing you give, including the medications that you give. Is it syrup or tablet? Is it dextrose containing? By the way, even tablets contain some amount of carbohydrate. So the tablets, the brands that we choose, have the lowest possible. So that's your first step to cut out the glucose. Only then the dietitian's thing comes in, and there the dietitian makes a plan. Then you follow the plan, and then you're monitoring the glucose and the ketones. And then if the glucose and the ketones are not matching, the glucose is not low, if the glucose is not between 60 to 80, then you know that your calculation is wrong. Ketones are not achieved, calculation is wrong. Go back to the board, to the drawing board. Go check again. So this is a dynamic process. This is not a fixed formula. This is why you need the dietitian, because every single child gives us a different challenge.
Okay, thank you.
This is not aimed at making you a ketogenic dietitian. I can calculate the diet, but I can't do it myself, having worked with so many children on ketogenic diet.
I think that is the bottom line, The bottom line is we have to work as a team. It is not something that we as intensivists can just like that start. And also the monitoring, especially when KD kids come to us, people panic. They just see the glucose levels and then they just kind of, push fluids and do such things. So these are the things that we have to be very mindful of. especially when children are on KD. Yeah. How frequently to monitor what, the sugars, all of these. So I think we need more experience as well. And we need to make sure that we are reviewing that on a daily basis, just like how we review our patients. Diet also should be reviewed, and where we are doing, just like what Anne said, really like a fine tooth comb. You have to just go through the basics. Yeah. I think that was quite a useful session. Thank you, Anne, so much for pitching in spite of all the challenges you're having. Thanks, Dr. Malathi.
Thank you, ma'am. Thank you, Dr. Ann.
Thank you, Dr. Malathi. It was very, very useful. Bye-bye. Thank you, Dr. Sujata, for the opportunity.
Thank you, everyone.
Bye-bye.
Thank you, everyone. Thanks.
Thank you.